Hi, everyone. Welcome to today's webinar. Um, it's the top of the hour, so we will get started. Thank you for coming. This is part three of our three-part series on improving cancer care for rural communities. My name is Nora Barnett, and I am a health professions outreach specialist at the Network of the National Library of Medicine, Region 6. I'm joined by my colleague, Miles Diaz-Castel, who will be providing technical assistance and monitoring the chat box with me. Today's webinar is a provider's perspective on building high-quality cancer care programs in rural areas. We are pleased to host our guest speaker today, Dr. Daniel Kohlmorgen, MD, FACS from Mahaska Hospital. Before we get going, let's go over a few logistics. So you'll see a Q&A box as well as a chat box on the bottom of your screen. Please use the Q&A box for any questions for our guest speaker and the chat box to share your comments or if you have technical things that you need help with. We'll queue up all of your questions and then we'll have time for a question and answer session at the end. Closed caption is available by clicking on the icon with the three dots at the bottom of your screen and then selecting captions. This session is being recorded and it will be made available to all attendees within 2 weeks. Continuing education is available in the form of certified health education specialist contact hours, nursing education contact hours, and Medical Library Association contact hours, or I guess I should say one contact hour of each. You can claim your continuing education by filling out the evaluation after the presentation. We'll give you a link to that evaluation. And even if you don't need CE, we would really appreciate it if you would fill out that evaluation as it helps us improve future programming. This webinar is sponsored by the Network of the National Library of Medicine. For those of you not familiar with the Network of the National Library of Medicine, or NNLM, we are a program of the National Library of Medicine, which is the world's largest medical library. The National Library of Medicine is one of 27 institutes and offices of the National Institutes of Health, or NIH. NNLM is made up of 7 regional medical libraries and numerous national centers, such as our National Training Office and our National Public Health Coordination Office. NNLM offers a variety of training opportunities, including webinars like this one and classes, and also periodic funding opportunities through its regional medical libraries. Now, it is my pleasure to introduce our guest speaker, Dr. Daniel Kohlmorgen. Dr. Kohlmorgen is a board-certified surgical oncologist and healthcare executive, currently serving as Vice President of Medical Affairs at Mahaska Health in Oskaloosa, Iowa, where he also practices as a surgical oncologist and general surgeon. He earned his Bachelor of Arts in Biology from Dartmouth College, from the University, and his Doctor of Medicine from the University of Iowa College of Medicine. Dr. Kohlmorgen completed his general surgery residency at the University of Utah and a fellowship in surgical oncology at Roswell Park Cancer Institute. He is certified by the American Board of Surgery with advanced training in trauma, laparoscopic, and robotic surgery. Throughout his career, Dr. Kohlmorgen has demonstrated a strong commitment to education, quality improvement, and advancement of cancer care. He has received multiple teaching awards and honors recognizing excellence in education and leadership. He previously served as the medical director of the John Stoddard Cancer Center at Unity Point Health, Des Moines, and chaired multiple surgical and oncology governance committees. Nationally, he has been active with the American College of Surgeons, including service as a Commission on Cancer Liaison and National Fellowship Representative, and has contributed to the Society of Surgical Oncology's Committee on Quality and Outcomes. With a career spanning clinical practice, research, education, and executive leadership, Dr. Kohlmorgen brings a unique perspective to discussions at the intersection of surgical oncology, quality improvement, and healthcare transformation. His work reflects a consistent commitment to advancing patient-centered cancer care while fostering strong clinical teams and organizational culture. Without further ado, please join me in welcoming Dr. Kollmorgen.
Without further ado, as you said. First, I hope everybody can hear me, but thank you to the network of the National Library of Medicine for the invitation, and certainly thank you to Nora and Miles for their assistance, including just now. I'd also like to thank Aaron Seaman, Mary Charlton, and Ingrid Lizarraga at the University of Iowa for the connection in having this, moving this forward. This is a list of my conflicts of interest, all my corporate subsidies, and my YouTube channel address, all of which are none. If we talk about quality in a rural location, the first thing we need to do is talk about quality in general. And in 2001, the Institute of Medicine set out the STEEP acronym for the definition of quality. As many of you are familiar, quality medical care is safe, timely, effective, efficient, equitable, and patient-centered. In cancer care, that means the whole continuum of care, from prevention to screening, diagnosis, treatment, survivorship, and end of life. Quality can be measured in a variety of ways, whether it be through process or following certain guidelines, and certainly it can be followed in terms of outcome with things like survival rate, recurrence, complications, etc. Increasingly, as many of you are aware, that patient-recorded outcomes are also followed. The idea of more than Press Ganey patient satisfaction, but return to function as evaluated by the patient is becoming increasingly important. And when we talk about rural cancer care and quality, there is a paradox that we have struggled with for years. That if you look at straight data, there are fewer cancers identified in a rural population. But when they're identified, they're at more advanced stages, which leads to worse outcomes. And the question is, in these days, even though we're learning more about our genetic codes, it's about location. And in rural cancer care, we are very aware that your zip code is more important than your genetic code in terms of outcome. And our challenge in a rural location is to address that. The question is, why is that the case? And that comes down to the challenges, vulnerabilities, and issues that we see in rural cancer care. Oftentimes, providers are working at the edge of their clinical scope, at their capacity, and the facilities are delivering at the edge of their ability as well. So they're pushing the envelope. Social determinants of health are a huge factor in this situation. Education and health literacy tends to be a challenge. Economic stability, as listed here, and certainly environmental factors, including food insecurity, clean water, and social support. In rural locations, obesity, smoking, diabetes, and radon exposure are higher across the board, which is different than other locations, or in urban or suburban locations. And the barriers to care may be different, but transportation is a big challenge for us. Access to broadband, staffing and recruiting to smaller towns and locations, and the availability of oncology specialists. The definition of quality is the same in all locations, but can rural locations deliver that? That's the challenge. There are disparities, and some of the data includes across the board higher mortality in non-metropolitan areas for all major cancer sites. And for example, the colon cancer mortality in the years 2016 to 2020, in retrospect, had a 20% higher overall mortality rate. As I mentioned, those barriers can be geographic, but also structural, economic, and at a system level. System level are things like infrastructure, ancillary services, availability of navigation for patients, and so forth. The result, as I mentioned, is a lower screening rate. There's lower concordance with established guidelines, and there's limited access to ancillary services that oftentimes aid in the care of cancer and care of the cancer patient. When we talk about cancer in rural America, what we need to recognize is that rural practice is not simply a smaller version of the urban or suburban model. Compared to non-rural areas, we have more tobacco and alcohol-related cancer in rural locations. The stages of diagnosis are usually more likely to be regional and distant. Screenable cancers are even found to be more distant because of the lack of, because of the barriers. Even lung, colon, and cervical cancers can be missed or not diagnosed because of a limited screening. And in general, the trends, we have a lower incidence of breast and prostate overall, but even with that, a higher death rates, as I've mentioned. If we go now and boil down into the state of Iowa, which is where I practice and where we want to focus on our experience at Mahaska Health, we have had 6,300 deaths annual in our state from cancer. The leading cause of cancer death is lung cancer. The most common cancers are breast and prostate and lung, which reflects national trends, but together those make up nearly 50% of all of our cancers. As I mentioned, there's a high incidence of alcohol-related cancers. And most alarmingly, the overall incidence of age-related, age-adjusted incidence of cancer, Iowa is number 2 in incidence, but overall, number two in incidence and number 1 in the rate of increase. This is the map of Iowa. The darker colors are where the higher incidence of cancer is identified, as you can see from the heat map code in the top right. In general, for the greater population, this is the age-adjusted rate of cancer incidence per 100,000. The U.S. average is in the 430 to 480 range. And you can see in Iowa, that number is around 500. The pin that you see here, the marker, is a location of southeast Iowa, where my practice is located. This is Mahaska County. And you can see we're in the band of some of the darker, higher incidence locations of cancer across the state. Wanted to go into a little bit of details of Mahaska County and Oskaloosa, which is the county seat. The population of the entire county is 22,000. Our town has 11,000 plus residents. It is a very homogeneous demographic, with 90% being Caucasian or white. Median age 39 years. Median household income around 62,000. And our economy is based on local manufacturing, healthcare, and there is a small college here in town. So there's education from the elementary through college level. More about the county of Mahaska County. The social determinants of health, poverty rate is around 11%, which is around the same as the national average. The level of higher education is below the national average. There is more insurance coverage in the state or in this location in the county relative to national averages. But unfortunately, food insecurity is also higher than national average. We also have significant comorbidities as listed here. The leading cause of death in our state is heart disease, with cancer right behind that. We have higher than national average incidence of diabetes, stroke, and overall disability. So when you think of these as the background as to where we are and what we're working with as far as access, social determinants, and some of these other factors, how would we describe success in rural cancer care? And certainly we need to keep in mind the Institute of Medicine's definition of quality with the STEEP acronym I mentioned earlier. But from my perspective and view, we want to build guideline concordance. There is good data that following national guidelines improves outcomes. Certainly having multidisciplinary access and support is important. That includes not only medical providers, but also other support services and ancillary services like genetic counseling, nutrition, occupational and physical therapy, and so forth. We want to monitor and measure our outcomes, and we want to be able to provide consistency. But sometimes in a rural location, and what I want to focus on is a bigger challenge is just having that access to care and make sure it's both sustainable from a financial standpoint and from a staffing standpoint. In order to do that, we need to build on the strengths of what we see in rural providers and in rural location. And having been in Des Moines and a larger population for nearly 25 years, when I moved to Oskaloosa and practice here at Mahaska Health, there are strengths in the provider system in a smaller town that may or may not be the same as in a larger town, but we need to build on these characteristics. Like I said, most providers and most staff is working at multiple levels at the edge of the scope and doing multitasking. Relationships are strong, as you would imagine, in a small town, in a small county. Patients tend to be trusting and loyal with their provider. You don't see the fragmentation and the competition that you'd see in a larger town with multiple health systems. There is a strong sense of community. We're the only player in town from a medical standpoint. The providers and the community members are willing to serve. The culture tends to be fairly consistent throughout the town, whether that's based on the rural location or faith-based commonalities, but that is fairly consistent. And the nice thing about being small is there is the potential ability to be nimble and to adjust with a small system and a small medical staff that we can adjust and work together if we build it correctly. Before I jump into the details of what we did, I want to have done so far. I want to talk about Mahaska Health and what's gone on in the last 4 or 5 years. It certainly has been a journey, and it's been a process, and we certainly have not reached any destination. But this is where we started and where we're headed. I started in 2022, and this initially did consultations. And the first thing that I noticed when I came in, we had one radiologist who would travel around to multiple small hospitals. They'd be available about 2 hours a day. If an overread or a second opinion or something was required, it was difficult to obtain. You'd try to get a hold of them, but they're also driving around, moving to multiple spots. There was one visiting medical oncologist who came once a week and sometimes 3 times a month because they would have inpatient duty, and they were busy. On occasion, that medical oncology clinic would see 40 or 50 patients in a single day. In 2025, 3 years later, we are up to 200 index cancer. We have now arranged and set up with a radiology group who's 3 days a week, present 3 days a week, and they are now providing biopsies and image-guided interventional radiology. We have hired a medical oncologist and brought him in-house for full-time help. And we have reviewed over 50 cases at our tumor board on a regular basis. Looking forward, we are in the process of adding a PET CT scanner and have a new young general surgeon who will be joining us next summer. Our guiding goal has been to get to COC accreditation, and we're hoping for a site visit later this year as we work through the process of building our cancer program. So that's where we were and where we are and where we're hoping to be. I wanted to walk through the steps from my view as to how we got there or how we've proceeded so far, and then share some of the lessons we've learned along the way, including the successes and maybe some of our mistakes. First thing I would say to anyone building this and working this way is you have to know yourself and you need to look in the mirror. And it seems maybe kind of trite or silly, but you have to have a mindset that is bigger than just worrying about the business bottom line. The idea of having a growth mindset or the idea of abundance is really important. This is a process, and you need self-awareness to know where you are personally, but also where your medical staff and the ancillary support team is. Abundance is the idea that there are, rather than working at thinking about what our disadvantages and challenges are. It's the idea that there are many people in need. There's plenty of work to do, that we can use collaboration and creative thinking to innovate. We can focus on creating better outcomes for the region rather than competing for a limited pool of patients. And as we build that, we are able to attract patients and even especially providers who are looking for something bigger and more meaningful. Certainly compared to other hospitals where I have worked, the idea of having a win-win for Southeast Iowa, how can we improve care throughout the region, as opposed to a zero-sum game attitude. We're going to build and take cases away from these other sites. We want to see how we can build things so that the smaller surrounding hospitals, that we can work together and improve patient care so that it is a win-win for the region. And so part of looking in the mirror is, besides what is your attitude and your medical staff attitude and your administration's outlook, is what do you currently have in your hands? What specialists or providers do you have? What non-provider support do you have? How do you work your referrals at this time? Is it ad hoc, or is there a structure? And certainly having the support of the administration and a board of directors that understands the importance of providing care and not always necessarily striving to maximize the financial margin. And there's always the physical plant things at any hospital. There's always the challenges of space and time. Step two, from my standpoint, is to collect outside opinion. So you look within yourself, you look within your hospital, you look within your medical staff, but then how do you look to others? We started with the Iowa Cancer Registry to assess where we were as far as number of cases, stage of cases, types of cancers. We went through our data on the American College of Radiology, especially related to mammograms and the BI-RADS category. We went through our HCAHPS information from CMS. We certainly looked at the Press Ganey reports. And then we reached out to those around us for us, such as mentors, national societies. We even had a rural hospital expert come in and help us with strategic planning retreat. And we gained enough information and experience from that we are now having that on an annual basis to help everybody get onto the same page. And what we realized as we built that is that this is information's out there, but you have to take the time and the effort to dig that out and really not just look in the mirror, but look and see how third party views your institution. Once we had that kind of information, we started to go out and share that with the medical staff and identify those key stakeholders that would understand and process that. First, you provide the data, and then most importantly, listen. And this is my reminder to mention that the most overlooked and underappreciated leadership skill is listening. The idea then, when we had this information, was not to go out and dictate a situation, but have a grassroots attitude and say, hey, we tend to have more stage 3 and 4 cancers. We tend to be behind on screening to start with. And then we got hit by the pandemic where everybody fell behind on screening. What do we want to do about this? Is this important to our region? Based on that, we started to set priorities with members of the medical staff. And importantly, we identified what I've been told are called the mojos and the no-jos, and the differences between Dr. Jekyll and Mr. Hyde. The no-jos are always going to be that 20% that think that we're crazy and we're banging our head against the wall. It's that scarcity attitude, whereas the Dr. Jekylls are looking for the positive, that abundance attitude, and how can we improve the care of the people in our community and in Southeast Iowa, and how can we help the surrounding hospitals if we have things that we can help them and they can help us. So again, that win-win outlook. Step 4, after we kind of built some vision and idea that we were behind on screening, we were finding more advanced cancers. How do we build that? What provides us external structure? We have an idea of where we want to go. What gives us that support, or gives us a structure to build on? And that's where my prior experience with the Commission on Cancer, I understood that we didn't need to reinvent the wheel, that we could use the accreditation process to go through and start to piece together building blocks that would improve our cancer program. certainly the first thing, most importantly, is a multidisciplinary tumor board. It doesn't have to be a large group, but the fact that you could review simple and complex cancers together makes a huge difference. You know, it used to be in medical school, they spent 4 years teaching you how to take care of all the different types of disease and so forth. And now nobody has all the answers on cancer. We need to share information, and we need to input from multiple specialists and multiple ancillary specialists that provide other parts of care of the patient and their families. We need to stick to evidence-based pathways. Those have been shown to improve outcomes. Going back to tumor board, there's usually a 20 to 50% even change in management of the patients, whether it be based on radiology review or pathology review. That multidisciplinary review makes a big difference. We want to make sure we stick with the national guidelines. We want to try to identify our local barriers and address those. These are all standards put together by the Commission on Cancer. And in order to become accredited, we need to build things to do this. But most importantly, and I'll come back to this more later, is the data submission. When a facility is accredited by the Commission on Cancer, we then can get nearly live or up-to-date information on how we perform. And it's that feedback and that data that makes a difference in how the program goes. I'm a big believer that data influences behavior, that people mean well, but if they don't know how they perform and where they stand, it's hard to adjust and improve. When we talk to the medical staff or administration of what's the point of Commission on Cancer accreditation, lots of them will say, what's the point? It means a bunch of meetings. It's going to cost money. And what I have experienced in several locations now is that there are multiple things. Number one, it improves cancer care, and that should be enough to explain the reason to have accreditation or pursue accreditation. Number two, the ancillary volumes, whether it be imaging or genetic testing or OT, PT, nutrition, those ancillary volumes will increase. And certainly the next generation of oncology providers are learning these things and work through accredited locations in their fellowship and in their training. So recruiting a new cancer provider without a COC accreditation, without a tumor board, without standards and data will be increasingly difficult in the future. One of the nice spin-offs is that having these meetings with a common goal, we all work in different directions in our different specialties, but it has helped to improve the cohesion of the medical staff and to communicate. And it's taken down some of the silos. Even in a small town, there can be silos because we get so busy doing our thing. But as we work towards a common goal, some of those silos are broken down. We've seen that cohesion, that communication spin off into other service lines, and certainly working towards accreditation with the prevention and screening events that are required in the standards from the COC. The community is more aware of what we're doing and how to participate in improved cancer care throughout our town and our county. And eventually, as I said, the National Cancer Database feedback, to me, is the main reason, or one of the carrots, so to say, of why we want to be accredited. We have access to that data. How do we do? How have we done in the past? How do we compare to others? And that certainly helps to form vision and future activity. Moving towards accreditation and going through these, it's not, you don't swing for the fences. You don't need to hit a home run. I would say we want to go for the low-hanging fruit. And what I mean by that, things that we did in the bigger town at a larger center that you took for granted, just doing those basics and getting together and starting a tumor board. And it can start as a small case review with just a few providers, but it can start to make a difference. And again, certainly we want to preach to the choir and move the mojos, those who are enthusiastic and involved. There's always a certain percentage, the no-jos, who are going to either not join in or they'll come kicking and screaming. But in my experience, I don't spend my time on that. They'll come along if and when they see the value. When you communicate clearly and then you deliver on that vision, then you start to build trust. And I think whether it be within your own medical staff or the community or with other institutions, trust is a big thing that oftentimes we're missing in medicine these days. And when you build that trust and you stay together and you have multiple projects and outcomes that you move forward and you're transparent about it, then you start to get momentum. And so these baby steps start to snowball into a sense of, wow, we can move the ball. We do have some upside where there is this abundance attitude and it's growing. And the important thing, along with the low-hanging fruit, is to not to try to start everything from scratch. We use some existing programs, we use existing relationships, events that we were having in town, and we overlap those with some of the growth in our cancer program, right? Rather than trying to start everything brand new at the beginning. And then the Hawthorne effect, everyone gets tired of me talking about that. But certainly as you start to focus on returns to the ER or start times in the OR or appropriate staging or compliance with pathways, those things that are observed tend to be things that are measured tend to be improving just based on the fact that they're being measured. So as we've gone through those steps, as I've kind of boiled it down into those 5 steps, some of the specific things that we've worked through, as I mentioned, the existing events. So the hospital had a women's health night every fall, and we built that into oncology education time. We developed a panel of our physicians. We talked about everything from imaging to medical treatment to screening to OBGYN care, overlapping in all those. And another event with the local high school and college was when the students came in for their physicals, we could overlap that with education about sunscreening, some of these behaviors and habits that affect a lifetime of health when we try to catch people early on. So we won an event with screening for skin disease, skin cancers. There was an annual tractor ride that we've had with the local farmers. They can come in and have a farmer's breakfast, but they can also have a PSA drawn while they're there. So these existing events, how can we put a oncology spin on that and not try to, as I said, reinvent the wheel and do a brand new event? One of the things we did with the American College of Radiology is every mammogram is categorized along a BI-RADS score. And we found with the prior radiology system that there was a lot of BI-RADS too. And the ACR will have standards that there's a certain number of mammograms, statistically speaking, who should be in this kind of not 100% normal, but no concerning findings. And those could return in 1 year. But when you look at the distribution, if there's a lot of BI-RAD2 and a low number of BI-RAD3s, then the follow-up changes. And we found we had a disproportionate number of BI-RADS2. And as we changed our radiology coverage and department, suddenly there were more concerning findings on mammograms that either may have been changed in their review or were more detailed in review. And there were more follow-ups, more 6-month follow-ups, more biopsies. And we've had more cancer diagnoses because we've changed our radiology approach. As I mentioned, with the development of the cancer program, the cohesion and the attitude, the culture growing and spinning into other things that are not oncology. So ERAS, or enhanced recovery after surgery, is the idea of limiting narcotics and opioid use. And we were communicating and hitting on cylinders. And in the summer of 2023, we began a limited or minimal narcotic program for our cancer program, for our surgery programs, including general surgery, urology, OBGYN, orthopedics. And we reduced our narcotic use by nearly 92%. And again, we have had this strategic retreat that we initially started early on, but have continued. We used Eric Stell from Stroudwater Associates. He helped us to develop our top 10 actions, again, across the hospital, not just to the oncology line. And we realized at that point that we really need data, that we think we're doing these things, but it's really hard to tell what's going on without having clear data analytics and data collection. Everything is a bowl of cherries and has gone perfectly, but I think that's never the case. Some of the missteps we've had along the way, we started out with a radiology group when we first made our change. leaving the single radiologist, and they were here for 6 weeks and turned around and departed. So we had 6 weeks notice that we were going to have no radiology coverage. And so we really had to do some scrambling, and we're fortunate to find the arrangement that we currently have. We thought that we could have our navigators multitask and have them trained to be oncology data specialists, so they formerly called tumor registrar. That is a significant amount of training, and that did not go far. So we pulled back from that and have contracted externally to have our data abstracted. We thought we were growing well enough that we brought in architects and spent a fair amount of money on thinking on how we could build new ORs, but we refocused that to an infusion center rather than building highly expensive square feet. The infusion center was certainly an investment, but not the price that we would pay for new ORs. And we realized also culturally that there were some alignment issues. The traveling specialists oftentimes were here but not involved. They didn't have maybe the same mindset. We got away from or had to adjust our compensation model. Coming from Des Moines, where it was the practice I was in was all about collections and RVUs, and here we value the care of the community, and we follow RVUs in production, but it's not the only thing that we focus on. And then also helping the board of directors, who are external business people here in the county, understand that a cost-based financial arrangement at a critical access hospital is different than running a business where you're maximizing your margin. Our goal is to have a positive margin, even though it may be narrow, but if we would rather have a small margin and reach out to the surrounding community than necessarily we'll try to run a business where we're maximizing our margin. There's a different set of priorities. Again, some lessons along the way. Learning from these things, I learned as a surgical resident that if there's a problem, you're better off trying to fix it than to do nothing. And I think we continue to keep trying, prodding, trial and error. Certainly change is the one constant. The accreditation process in the last year, we've been working for 2+ years to meet the national COC standards. And in the last 6 or 8 months, they've announced that there is now a rural pathway for accreditation. That kind of moved underneath our feet, but we're still pressing forward for the full accreditation because that's what we've built for. And the standards, as data changes, the standards evolve. So the COC standards in the next year are moving more in different directions. Some standards are modified, some are dropped, and new ones evolve. So as you build your program, you have to stay nimble and adjust as you go. The other paradox in COC accreditation is that the standards, whatever they may be, are blind to volume. So if you have a 1,500 patient or cancers in your data annually, or 50, the standards are still the same. But the infrastructure, as far as the data collection and the ancillary support, whether it be genetics or physical therapy, as I mentioned, nutrition, navigation, those are fixed things. And so there's not necessarily a correlation. There's an expensive infrastructure that is harder to meet in a rural location. So we've had to continue to be creative. And certainly isolation doesn't work. And we have been fortunate to network with a group called ICAN or ICAN. And those relationships started personally. And as I learned more about the Iowa Cancer Registry, connected more with the University of Iowa and learned about this network, and it has certainly helped us. And so I want to talk a little bit about the Iowa Cancer Affiliate Network. This is a group that is based out of Iowa City and is based on a grant at the University of Iowa with Dr. Mary Charlton. And what they've done is developed a collaborative group where they will go out. They certainly now have, I believe, 6 hospitals in the network around the state. They aren't owned necessarily or operated by the university, but they are identified as wanting and needing help. And the ICAN team will help us to work on standards. They help with peer support for our directors and navigators and data folks. There's education and training, and it really works on driving data forward and assisting us towards accreditation with the COC. As I mentioned, it's grant funded, which is concerning in the long run for viability, and hopefully that will continue. And I'm sure they would appreciate me saying that there are always university issues. Sometimes the right hand at ICANN doesn't know what the left hand is doing in terms of administration or the Department of Surgery or medical oncology, but that's part of being in a bigger institution from my view. You know, the ideal network would be one that reduces isolation and increases capacity, provides depth and support, and still is a win-win. And these are some of the things that we have experienced with ICANN. Data exchange, best practices, economies of scale, local support for our team, and becomes a trusted partner. That would be the ideal situation. Unfortunately, when you look around the country and read about other networks, there are problems. One of those is that it tends to be a one-way relationship. We'll be happy to help you, but we're going to take all the patients. And so the larger institutions think of a network as a funnel for referrals, and we never see the patients again. And so it's important to have a win-win relationship with the networks as well as the other regional hospitals. The challenge with a network can be that the different hospitals have different capacities and different infrastructure. So again, the network needs to have that flexibility, which can also be a challenge. And certainly long-term financial viability. How does it stay? If there's no longer a grant, is it a subscription model, or are there other ways to make a network run in the long run? And it comes down to making sure that it's not a competition, that their local autonomy stays, and there's a clear understanding of who's in control of what pathways. The ICANN model was modeled after the Markey Cancer Center affiliate network in Kentucky. And they do the same thing where they really focus on the COC accreditation. They help us understand the insight and interpret some of the standards from the COC. They have helped provide templates for our minutes and some of our projects so that we fill out everything to cross the T's and dot the I's. And one of the things they've now been building as there's more members in the ICANN network is we connect with other hospitals so we can share best practices or challenges. And this last fall was the first meeting of the ICANN member hospitals, and it was a great way to network and understand what else is going on. So as we go forward, you know, I think there are increasing opportunities in rural cancer care. You know, success in a rural cancer includes, as I mentioned earlier, access and sustainability. If we could somehow figure out how to pool resources and not just the best practices, but if you think of the FTEs that are required for COC accreditation in navigation, genetic counseling, survivorship, palliative care, clinical trials, if somehow we could pool these and share these resources and do a telehealth, telesupport, this would be a great way to move forward, but still provide that capacity and expertise in the rural location. And a sustainable network could be created where we have a clear partnership, where there's somehow there's shared costs, there's governance, but that we have clear relationships. So when a patient has needs to be escalated to a tertiary center, there's a pathway, that there's not a problem with over referral or under referral, and that we have a clear understanding of what should be treated locally and what can be done elsewhere. And then again, as I mentioned, sharing data and sharing dashboards, so we're all looking in the same mirror, so to say, and we are working towards the same goals across the network. To me, as I mentioned earlier, keeping our eyes on the prize is data. Like I said earlier, I really believe that the high quality rural cancer care depends on high quality rural cancer data. And so I think data changes behavior. And when you are accredited by the COC, then you become part of you turn your data and information into the National Cancer Database, and you can see the rapid cancer reporting system on a regular basis where you are in terms of 12 or 13 different quality measures. Are your patients getting referred in time for post-lumpectomy radiation? Are they getting appropriate chemo at the right time? Are they having appropriate follow-up? These are not results that come back a year or two later, but they come back within days or weeks, maybe months, so you can see, are we up to speed? And you can change your behavior. NCDB covers about 70% of new cancers in the country, There's monthly submissions, there's real-time updates on those quality measures, but the surveillance, epidemiology, and end results data, the SEER database, is different. It seems to be more important and useful for incidence, mortality, and disparities, but doesn't have the real-time data that we would see with the NCDB, but provides a different view. Certainly, we're starting to see, even at the rural location, of work towards value-based care. And so getting a hold of insurance claims data, what's the cost of care, what is our complication rate, who gets readmitted, what number, what's the utilization. These are all different pieces of the data puzzle. As I said, keep changing the way we look at ourselves in the mirror. But going forward, the fee for service is slowly dwindling, and value-based care, even in a rural location, will continue to develop. So as we think forward about the Mahaska blueprint, and not that this is the answer to all problems in a rural location, but the pattern that I've seen as I look back over the last few years is things start with the medical leadership starting the discussion. They don't dictate the situation, but they just open the discussion. This discussion leads to awareness of how things are locally in terms of what the local resources, outcomes, and abilities are. And a vision is developed and clarifies the type of actions that can be taken. We then use the COC standards to provide structure to move our actions forward. It gives us accountability. The ancillary staff locally will then develop and execute those plans once the vision is built with the local medical staff and administration. The standards give us a structure, and the ancillary staff and services begin to execute those plans. The partnerships outside our hospital with the regional areas and surrounding hospitals will increase our support and certainly can increase the capacity. And then, as I've mentioned repeatedly, the data transparency really changes behavior. It helps us go forward. And as we have that data, we go back and start up at number one. Now that we have new data, let's have a discussion. Once we have that discussion, what's our vision? Has it changed? What are our actions? And we keep repeating this cycle to adjust as we go. Again, I would go back to the mindset to start with is the key, that attitude of a win-win versus a zero-sum game. It's not me against you in a rural hospital. It's how do we improve care for the area, for the region. I think in understanding that high quality is more important than market share, especially early on, that market share will grow. There may not be much competition locally, but the competition is more of holding yourself accountable and avoiding leakage of patients that could be treated locally outside of the system. And understanding that improving the service is more important than increasing the profit locally. And again, when you have a good mindset, that positive mindset, and it spreads throughout the medical staff and throughout the community, then you start to develop a culture. And it's hard to move things forward without that kind of a culture. So in summary, I would say, first of all, quality is universal. Rural medicine is not a small version of urban medicine. We have our own challenges and our own barriers. But awareness builds vision and identifies those barriers, and each of those are created and understood locally. The accreditation process requires structure and accountability. That networks can help, but they can also be a hindrance. So it's important, but go forward with eyes open. And again, data drives behavior. I think I've said that more than once. And again, from my view, culture is the glue, and it has to be developed locally. It doesn't come up from the top down, and it isn't exported or imported externally. So from my perspective, it's not enough to do your best. You need to know what to do and then do your best. And when we talk about building high quality cancer programs in a rural setting, the real question isn't whether rural hospitals can replicate an academic center. The question is whether we can design care intelligently within the realities that we have. Rural cancer disparities are driven by distance, delayed diagnosis, transportation barriers, fragmentation, but not by the lack of commitment or capability. We don't have to duplicate everything to deliver excellence. We have to optimize what we build. Rural cancer care succeeds when it's intentional, when it's disciplined, and when it's connected. Geography should not determine outcomes. and thoughtful design with local leadership makes that possible. I appreciate your attention and would be happy to answer any questions. While we're starting, I'll mention in the last week, we were named in the top 100 of critical access hospitals out of 1,400 in the country. So that's been a nice carrot for our medical staff and our team here at Mahaska Health.
Thank you, Dr. Kollmorgen, for such an insightful presentation. We truly appreciate you sharing your expertise and experience with us. We're going to move into the question and answer session. So please drop your questions into the Q&A box, and we'll get to as many as we can in the next little bit. I'll start off with one of the questions that's already in the chat box, or excuse me, in the Q&A box. Someone says, we currently have a hub and spoke model in rural Montana. How do you build such a model you were describing with such a very small population of patients at these rural spoke sites?
Okay, I'm still on. I think that's a challenge. It's almost like building a hub and spoke out of the rural locations. Can you be affiliated with one or more larger location, but then can you pull together a regional group to do tumor board? Are there overlapping services that you can provide? And part of that is getting the local providers together and like I said, developing that platform, that combined vision. So you have a hub and spoke, but if the hub is in Bozeman or Missoula or a larger location, can the spokes then develop spokes outside of them? Is there a smaller hub that can pool together providers throughout the state? I think that is the challenge, and getting them together in a way that doesn't feel like one location is trying to drive and dictate. So a lot of that building trust, building cohesion, and seeing that moving the ball together as a team would be the first step.
I was muted. Thank you for that answer. Our next question is, do you have dedicated outreach or education staff within the hospital that supports the partnerships and events? Or are there health professionals coordinating this work?
That's a good point. We do have a marketing and communication team that works across the hospital. And again, within the hospital, making sure we overlap and communicate clearly with them. So how can we do multitasking? Each provider and almost everyone at a rural hospital, as you know, is multitasking. And so when we do have an event and we do pull people together, how many things can we accomplish with that? Can we educate? Can we screen? Can we talk about prevention? As many of you are aware, the driver to most healthcare in a family unit is usually the mom. When she delivers a child, when she goes in for her screening and care, she brings her kids, she encourages her spouse. It's usually driven by the young moms who help to deliver that care. So if we can, a challenge in rural locations is OB and GYN care, and I'm sure that's true in Montana as it is here in Iowa. If we can take advantage of those times when they're in to say, hey, have you had your screening? Had your family had your screening? It's really understanding that someone comes in for a general surgery visit. Have they had their other screening? Have they had their colonoscopy? Have they had their mammogram? What's their cholesterol? What's their blood pressure? We almost work as extensions of primary care to offer those things across the whole spectrum. When we see a patient for one particular problem, we try to think of the whole patient.
You're really thinking of the whole person and the prevention. We have a question. Who is overseeing the COC accreditation at the rural sites?
I'm not sure exactly by overseeing. I think each location institution has to develop that, has to start the process. There is now in the last 12 months a new rural pathway. So the standards are the same. The COC, which the Commission on Cancer has developed that. They're a branch of the American College of Surgeons. And so there is now a new rural pathway that you can access and review. And some of the requirements are less stringent, but still include, once accredited, that access to that database, which to me is the key. So I hope that answers that question.
Yes. I think we have time for about one more question, if there's any more questions that people have. Um, we do have one. So you mentioned the shift that's led to more BI-RADS 3 versus 2 diagnoses.
Mhm.
Did the change in the classification thresholds improve clinically meaningful outcomes, like more early diagnosis, or did it just lead to more screening and follow-up?
Well, it was kind of a bubble. So a lot of patients who had been BI-RADS 2, which would be annual follow-up, as they had either more detailed or more focused review, they became BI-RADS 3, which meant 6-month follow-up. And some of those then went on because their abnormality changed to biopsy. So we had a little bit of a bubble of more cancers, more abnormals. And
Mm.
now, after a couple of years, that's kind of flattened out as I guess I would say the quality of the imaging has improved.
Mhm.
But as you can imagine, some of the stuff had been pushed along for several years, and we had some catch up to do.
Mhm.
So we're seeing now we had more cancers to start with because the screening improved, but
Mhm.
now we're plateauing and getting into earlier diagnosis.
Yeah. The last question is, are these hospitals critical access hospitals?
Yes, so everyone in the ICANN network is a critical access hospital. So we're a 25-bed hospital, and the others that we work with are the same.
Well, thank you, Dr. Cole Morgan, so much for your time and sharing with us today.
Sure, you're welcome. Thank you for the invitation.
I'm going to share the evaluation link. Can everyone see that? We will also put that in the chat box so that you can all have that evaluation link. Um, and thank you, everyone, for being with us today. Please fill out that evaluation to receive your CE credit and let us know um, what you thought. I will also just bring your attention to some upcoming webinars from NNLM on March 18th. We're going to have Advancing Disaster Preparedness and focus the highlight the Pediatric Pandemic Network. And on April 8th, we're going to have a webinar about finding sleep hygiene information in NLM resources. You can also see a full list of our upcoming live trainings and on-demand trainings, many of which offer CHES and CNE, on our training calendar at nnlm.gov/training. So I will leave this up for just a few minutes because some of you might want the link to the evaluation, but otherwise, thank you so much to our presenter and all of you for being with us today. I hope you have a good afternoon.